Good morning and welcome to the Department of Medicine Grand Round. I want to start by acknowledging today as September 30th is Orange Shirt Day. The Orange Shirt Day is worn today as a remembrance of the story of Phyllis Jack Webstead, a residential school survivor who had her new orange shirt that her grandmother bought her taken away on her first day of residential school at the age of 6 and never returned back. She never wore it again. This day is designed to educate and promote awareness about the residential school system and the negative impact it continues to have on Indigenous communities. This year, in light of the revelation of over 6,000 unmarked graves near former residential school sites, September 30th was formally designated as National Day of Truth and Reconciliation. Today, we honor the children who survived residential schools, remember those who did not, and affirm that every child matters. We have a collective responsibility to take action to move this country forward in reconciliation. I ask that today we all must take time to listen, reflect, learn, unlearn, and relearn. We all have to acknowledge and accept the truth as we move into reconciliation. We will do a formal land acknowledgement by our speakers. So our speakers today, are three fabulous PGY3 chief residents from Hamilton Health Sciences who are going to speak to us about a very important topic that we encounter in clinical practice, which is palliative care in advanced heart failure, bridging inpatient and community care. Our three speakers are Wendy E., who's hoping to become a nephrologist here in Hamilton as she goes through her fellowship, awaiting November results. And Thomas Mazzetti, who's gonna be a fabulous respirologist, and Yasmin Jajarmi, who will also be one of our nephrologists in the future. So without further ado, I'm going to ask our fabulous speakers to do a land acknowledgement and move on with our topic today. Go ahead.
Thank you so much. Thank you so much, Dr. Zan, for that lovely introduction. We will start our presentation with a land acknowledgement. We take this time to recognize that we are currently on the traditional territories shared between the Haudenosaunee Confederacy and the Anishinaabe Nations, which was acknowledged in the Dish with One Spoon wampum belt. That wampum used the symbolism of a dish to represent the territory and one spoon to represent that the people are to share the resources of the land and only take what they need. Due to the virtual setting of our grand rounds today, we acknowledge that other participants may be on different traditional territories, and we ask that you also take a moment to reflect on those who were there before you. In terms of disclosures, we have no conflicts of interest to disclose in our presentation today. As of 2016, heart failure affects over 600,000 Canadians and is rapidly on the rise. And it has been predicted that over 50,000 Canadians will be diagnosed with heart failure annually, totaling over $2.6 billion spent annually on treatment of heart failure. Advanced heart failure is a progressive disease with limited therapeutic options. Thus, symptom management and care directed by patient values become a critical part of heart failure management. Today, we would like to introduce a patient-centered collaborative model of palliative care for patients with advanced heart failure and what this might look like in both an outpatient as well as inpatient setting. Specifically, we would like to review the current literature on palliative and symptom management of advanced heart failure, as well as the role of the inpatient specialist. Next, we want to outline a multi-provider collaborative approach to palliative discharge planning, including the importance of involving family physicians through every stage of patient care. And finally, we provide an overview of community palliative care resources available in Hamilton, how to access them, and ultimately, what does dying at home truly look like for our patients? Through these specific objectives, we hope to demonstrate to everyone in the audience today that excellent palliative care in advanced heart failure does not start with a palliative care consultation. We'll begin in our outpatient setting, the heart function clinic, where we meet Mrs. Jones. She's a 74-year-old female who lives at home with her very independent spouse, and she has advanced heart failure with a reduced ejection fraction of 26% and suffers from NYHA class 3 symptoms. Unfortunately, because of her symptoms, she has had a progressive decline of her function at home and presents to clinic today to see what we can do to help with her symptoms. I pass it on to Yasmin.
Excellent. So I'll begin by saying that in order to adequately address the nuances of Mrs. Jones's particular case, we first have to have an understanding of what palliative care means and what a palliative approach means. The concept of palliative care was fairly recently reframed or re-envisioned as an approach, as opposed to strictly quote unquote end of life care. And I think it's captured best in the 2002 definition put out by the WHO. The WHO definition specifically states that palliative care is a quote unquote approach that improves the quality of life of patients and their families who are facing problems associated with life-threatening illness. It prevents and relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether those come in physical, psychosocial, or spiritual manifestations. Next slide. So the question becomes, how do we apply this palliative approach to patients with advanced heart failure, like Mrs. Jones, when we encounter them in the outpatient setting? The first step, I would argue, is to recognize that there are challenges that are unique to this population and to heart failure palliative care. For instance, the palliative care evidence in heart failure patients overall is not as robust as palliative care evidence in oncologic patients. We have studies, but comparatively less robust. As well, prognostication of heart failure can be difficult. For example, while most patients with stage D disease or advanced heart failure will die within 6 to 12 months, some may live much longer and can benefit from palliative approaches and care for prolonged periods of time when compared to patients with other terminal illnesses such as cancers. The distinction between curative forms of therapy and quote unquote palliative therapy or symptom-directed therapy is also blurred more so when compared to traditional oncologic patients, where there's a clear line between chemotherapeutics that are intended to cure or treat and management therapies that are directed towards palliation or symptom management. I'll talk about this more in a little bit. Next slide. Thank you. This leads to a very important key message or key point, which is that clinical trajectories and timelines that are applied to terminal illnesses like cancer cannot be applied reliably in the same way to congestive heart failure patients, because there are key differences in the pathology and illness trajectories. So in terms of the key differences, the first important key difference to keep in mind between palliative care in advanced heart failure and palliative care in other terminal illnesses is typically the timing of referral to palliative care, timing of referral to hospice settings, et cetera. Traditionally, patients in oncologic settings or in other settings with terminal illness are referred to hospice or formal palliative care supports when curative treatments have been exhausted. Usually this happens within the last 6 months of life. In congestive heart failure patients, this looks a little bit different. The timing of referral is different. We typically would consider referral when patients develop NYHA class 3 or 4 symptoms, or when they develop American Heart Association stage D disease. As well, other potential indications may be frequent heart failure readmissions, recurrent ICD shocks if there is an ICD in situ, refractory angina or symptoms, psychosocial distress of caregivers and patients. And these are all sort of indications that adjust the timing of referral as mentioned. The next key difference is around the prognostication of these patients compared to traditional palliative patients. The prognosis of traditional palliative patients, say ones with cancer, tend to correlate strongly with their degree of functional decline. It's important to remember, however, that in advanced heart failure, prognosis is much more variable, and illness trajectory is marked by exacerbations, worsening function, and then remissions. And there are also unique milestones in the illness trajectory, which the patient may or may not experience, including LVADs, transplants or transplant consideration, TAVRs, inotropic therapy, et cetera. And all of these mark the illness timeline and should be discussed with patients and families. The third point is around that line between curative therapy and palliative, quote unquote, palliative therapies. I touched on this a bit earlier, but curative medications and therapies may be discontinued when goals of care shift towards palliation in patients with other terminal illnesses like cancer. But in CHF, it's important to recognize that many of these therapies that were initially started with intent to prolong life are actually continued throughout the course of illness as they impact quality of life, even when they no longer affect the quantity of life. The last key difference to keep in mind is the degree of caregiver support and the requirements in this particular population, which arguably are actually increased compared to perhaps to other terminal illnesses, particularly when we recognize the prolonged nature of the degree trajectory and illness trajectory. So this leads to my next point, that advanced care planning and shared decision-making becomes extremely important in the outpatient as the disease progresses. And symptom assessment is also very, very key when patients are expected to potentially face discussions and options like transplant, ICD, mechanical or circulatory support throughout their illness course potentially. So generally, the structure of our goals of care conversations in the outpatient setting typically follow a similar structure or framework as other goals of care conversations, but with several specific CHF nuances. The first step, arguably, is to characterize and communicate the patient's clinical status. As a general rule, goals of care conversations should be formally addressed and documented in consultation notes so that members of the care team, including family doctors, are aware of the exact nature and timing of these conversations. This can help the family doctors springboard or even initiate ongoing goals of care conversations to support the family and the patient should one not get done as an inpatient or in other outpatient specialist clinics settings. The second step would be to estimate prognosis. In CHF patients, recognizing the uncertainty of prognosis is important, as the clinical course, as I mentioned, can be variable. But at the same time, it's very important to recognize the chronic nature of the illness and the inevitable death as final endpoint, and reiterating that and communicating that with compassion and kindness is very important in this setting. One can supplement prognostic information with certain predictive tools like the effect model, the heart failure survival score, or the Seattle heart failure score, together with our clinical impression at the bedside. Perfect. And the next point would be to solicit patient values and beliefs, which we often do very well in the clinical setting. And finally, the last sort of CHF specific step would be to review specific treatments and discuss CHF specific milestones. This step includes anticipating major treatment options and quote unquote forks in the illness pathway road. One example that comes to mind to illustrate this may be the role and deactivation of an ICD device if one is in place already. Generally, often ICDs add burden in the palliative care settings because although it prevents death from lethal arrhythmias, it doesn't actually do much to improve quality of life or heart failure symptoms themselves. In fact, it may increase the risk of prolonged death from pump failure and may actually lead to unnecessary or increased hospital admissions. In the palliative setting, the deactivation of the ICD, if one is in place, should be discussed as a potential milestone. And it's very important, I'll say as sort of a side note, it's very important that we do this because there have been reports, albeit mostly in the US, where patients are sometimes inadvertently sent to hospice settings with functional ICDs, which is quite problematic, as one can imagine. Many studies have shown that patients don't have a good understanding of the indications and the uses of ICDs and don't even sometimes know that there's an option to deactivate them. When we're talking about other milestones, we can consider milestones like hospital admissions and readmissions, the use of palliative inotropy and other hemodynamic interventions. And counseling patients on expectations around these milestones would be very key in advanced heart failure patients, similar to other patients. To go back to the ICD example, to give you a concrete example of what this may look like, you can counsel patients that they should expect not to experience pain or symptoms should they choose to deactivate their ICD. So counseling around expectations around these milestones is very, very important. All right, excellent. So the other big picture intervention, apart from having a good goals of care conversation, understanding what palliative care means and initiating the approach in the outpatient setting, the other big picture intervention we can offer in the outpatient is a detailed and thorough symptom assessment. It's very important to recognize that heart failure patients not only suffer from dyspnea or fatigue as a result of their disease process, but also have a high burden of other somatic complaints, including pain, insomnia, nausea and gastrointestinal symptoms, depression and mood disturbances, psychosocial and spiritual distress. There are several tools that we can use to quantify symptom burden and symptom degree, like the Edmonton Symptom Assessment Scale, the Memorial Symptom Assessment Scale, and so on. There are also quality of life scales that can be used to assess the degree of symptom burden. Wendy will be discussing some of the specific therapeutics that we can use to intervene on symptoms, particularly when we encounter patients both in the outpatient and inpatient settings. But the message that I want to leave you with here is that palliative care does not start with a palliative care consultation, as we had mentioned earlier. Specifically, what I mean in this case is, as internists, it is often within our scope to start palliative or symptom alleviating therapies. For example, in patients with dyspnea, we already tend to do this, and we already tend to intervene with hemodynamic therapies like diuretics, afterload reduction, inotropy, etc. When these symptoms become refractory, it becomes important to characterize them with these scales, and then to consider other management options in liaison with other expert consultants in palliative care, cardiology, such as low-dose opioids, supplemental oxygen, cardiac rehabilitation and exercise, cooling fans to the face, etc. So there's other things that can be considered. Palliative care symptom burden assessments and initial therapy is within our scope. And we can certainly make a big difference when we proactively apply a palliative approach to these symptoms early in the course of illness, even before we involve our palliative care colleagues. And I'll turn to Wendy for the next part.
Thank you, Yasmin. So now we're going to transition more to an inpatient setting. So 6 months later, Mrs. Jones comes to the emergency room as you're on call, and she's had a 1-week history of worsening dyspnea as well as bilateral leg swelling and NYHA class 4 symptoms requiring supplemental oxygen. She's admitted to the hospital for further management, and we ask ourselves, how can we apply this collaborative palliative care model in an inpatient setting? The first thing that we can do is inpatient symptom management. And as Yasmin mentioned, oftentimes when patients present with congestive heart failure, we reach for therapies such as our IV diuretics, our beta blockers, and nitrates as a life-prolonging therapy. However, many of these therapies that we use for patients in hospitals can also provide really important symptom relief. For dyspnea, for example, we're already familiar with the use of loop and thiazide diuretics, nitrates, ionotropes, ultrafiltration, for example, as a method of volume reduction and life prolonging. But I also want everyone here to think of them as symptom relieving therapies in a palliative care model. And once we exhaust our knowledge of symptom relief and patients still have refractory symptoms, that's when we can consult our palliative care colleagues for addition of other therapies such as low-dose opioids, for example. In terms of pain management, again, these are therapies that we're all familiar with as life-prolonging therapies, such as beta blockers, nitrates, calcium channel blockers, but they can also provide relief for anginal pain. And again, is when those symptoms become refractory, when we consider consultation from our palliative care colleagues for addition of opioids, and we can also consider referral to exercise training programs or cardiac rehab to help improve pain symptoms. In regards to fatigue, addressing patient fatigue is incredibly challenging. But again, many of the therapies we already do, such as treating anemia, as well as hypothyroidism and OSA, can have significant improvements for patients in regards to their quality of life. And expert consultation from palliative care can give additional benefits, such as potentially introducing stimulants as a therapeutic option. We cannot discount the importance of increasing home supports and exercise training in terms of managing fatigue, particularly as patient function declines. And finally, GI symptoms, I think, is incredibly important, as I'm sure we're all aware of being on the inpatient side to manage constipation, and there are many pharmacological therapies we can use. And we should also think about procedural options such as therapeutic paracentesis, where many of us might think of them as invasive procedures in a palliative care setting. But on the flip side, they also provide incredibly important symptom relief for patients, particularly those with ascites due to their advanced heart failure. And as you can see, overall, many of what we already do as inpatient providers follow a palliative care model. In addition to symptom management, we can also provide families and patients with education on the trajectory of their advanced heart failure, in addition to what we already do as an outpatient. The trajectory of advanced heart failure, as mentioned by Yasmin, can be incredibly difficult to predict, with many troughs and valleys that makes it challenging for patients and their families to know what to expect in the long term. As you can see in point number 3 here, the patient may have a period of clinical instability, but then start to improve clinically, but perhaps never quite reaching their baseline. And I think having the big picture and drawing this out, perhaps even in a schematic for patients and their family to see, can be extremely beneficial. In order to have these difficult conversations, some probing phases that you can use will be things like, what is your understanding of your health? Here's what the big picture of your heart failure looks like. What do you worry about the future? And these questions can be used to start a discussion about the challenging topics. And we can use our hospitalization as an opportunity to re-educate patients about the trajectory of their disease. And finally, what is incredibly important, and I feel like we don't do enough, and I know I definitely personally don't do enough, is that we need to empower patients through an action plan so that we can prevent future hospitalizations, particularly if the patient's wishes are to remain comfortable surrounded by their family at home. And this becomes particularly important during our COVID era, where we know that the hospital capacities are increasing, and patients are afraid of getting COVID if they were to come to the hospital. On the right here, I have an example of a self-check plan for heart failure management through the Heart and Stroke Foundation that you can share with your patients that can outline some of this action plan. But important things to consider will be that you have to be incredibly specific when you are educating patients on their action plan. For example, this would be like telling your patient, if your weight increases by 1 kilogram, please increase your Lasix by 40 milligrams daily. Instead of telling them something like, if your weight increases, call the heart function clinic or call your family doctor. Because for patients and their family, when these symptoms occur, they can be distressing. It is not always easy to reach clinic providers on an after-hour basis. So by giving them that specific plan, they know exactly what to do that can help them get through the night or perhaps the weekend before practitioners are available. In our collaborative model, like Yasmin mentioned, it's incredibly important to document all of these things in our discharge summary, or even better, to communicate it directly to the family physician. I know often we tell our patients, please call your family doctor, please call your family doctor. And the family doctors really read our consultation notes and hold on to our discharge summaries as guidance to what to do for outpatient management. We cannot assume this transfer of care model where when we're done with the patients as inpatients, we transfer care back to the family physician. We have to adopt this collaborative care model where we're constantly in touch with the family doctor so that as patients transition more from life-prolonging therapy towards symptom management or palliative care, that they don't feel like they're left in the dark in regards to their heart failure management. Next, we have to assess for patient understanding. And sometimes I use probing phases such as, do you know why we're changing your medication? To see if they understand what to do with their Lasix, or if they understand that the reason why we're providing changes to their medication is because they are in a different phase of their illness trajectory. And again, this can be another time to solidify patient understanding of their disease process. And finally, it is always incredibly important to involve family members and other supports that the patient may have, because as Tom will mention in his section of the presentation, the family and the family physicians are really the quarterbacks of the patient once they get discharged into a community setting. In regards to discharge planning as an inpatient, my model is to be proactive and not reactive in order to avoid future hospitalizations. As an inpatient MRP team, some of the things that we can do to help do this is by putting in a LIN referral, which I'm sure everyone here has done, but specifically put palliative resources within your referral so we can activate more palliative care nursing and home care support. And as I mentioned in the previous slides, providing patient education and considering the consultation of palliative care for refractory and difficult to manage symptoms. Again, we must collaborate and involve the patient's family physician by either calling them to provide verbal handover, which I know is not always possible, but if it's not possible, making sure to dictate specific action plan for worsening symptoms. And as Yasmin mentioned, dictating specifically where they are in their illness trajectory and whether or not you've had a goals of care conversation with the patient so that the family doctor is aware. And then finally, as a part of the discharge planning process, we can involve our palliative care colleagues to help manage those difficult refractory symptoms and help us come up with that outpatient action plan to provide to prevent future hospitalizations. As our patient, Mrs. Jones, has decided that she will want to be at home for symptom management and end-of-life care, Tom will then next take you through what this actually looks like for the family and what resources are available to them.
Thank you, Wendy. And so we reach a point with our case where our patient and their family have collectively made the decision that they wish to receive further care at home. But the question really is, what does home start to look like in this situation? From a resident perspective, it can often be challenging because it's no secret that we as residents spend the vast majority of our time providing inpatient-based care. And so from that standpoint, it can feel like we're discharging our patients into the void, into the great unknown, and into this sort of unclear set of circumstances where it never really clarifies to us what really happens. And this can be frustrating. This can be a frustrating experience for residents